Assalamualaikum. This is the second part of epilepsy presentation. In the first part, I have discussed the preconception counseling and the types of epilepsy. So, preconception counseling, as I have mentioned, is very important. So, in the if when patient becomes pregnant and she already knows that have, what are the risk factors of worsening epilepsy in pregnancy, and what are the risks involved in discontinuation of anti-epileptic drug on her own, and also we will tell her the triggers to for the seizure, such as lack of sleep and lack of sleep, dehydration are the triggering factor for seizures. So when patient becomes pregnant and she comes to us in the antenatal clinic, we will again discuss all the point of preconception counseling as well, the risk of congenital abnormalities, and her, she is taking folic acid to reduce it, and monotherapy of anti-epileptic drug, the lowest possible dose, and the type of anti-epileptic, and also we will tell how can we can diagnose neural tube defects, and how can give the option of termination, and we will tell her that there will be the risk of cognitive deficit in the child, even if there is no congenital abnormality has been seen. So in the antenatal care, multidisciplinary setting should involve an obstetrician with special interest in epilepsy, working alongside a neurologist with specialist training in epilepsy, or epilepsy specialist nurse, midwife, psychiatrist where required. So as these patients are, because of their condition and because of the side effect of anti-epileptic medications, these patients are depressed. So maybe psychiatrists are required for their mental health. And if there is a patient which has epilepsy along with non-epileptic seizure disorder, then psychiatrists will be involved in the care of that patient. All pregnant women with epilepsy should be provided with information about the UK Epilepsy and Pregnancy Register and invited to register. So all the women, 100% women will be registered to that pregnancy register. Women with epilepsy taking anti-epileptic drugs who become unexpectedly pregnant. So these are the women who did not come to us in the preconception clinic. They don't know the risk involved in pregnancy. They haven't managed the anti-epileptic medications. So they haven't taken the 5 milligram of folic acid. So these women, we will again should be able to discuss therapy with epilepsy specialist on an urgent basis, because we will not change the medication. We will not touch the medication. We will not decrease the dose, and we will tell the patient do not stop it on her own, and we will fix the urgent meeting with the neurologist. It is never recommended to stop or change anti-epileptic drug abruptly without an informed decision. So the next is increased risk of spontaneous miscarriage, antepartum hemorrhage, hypertensive disorder, preterm delivery, fetal growth restriction, and postpartum hemorrhage is seen in women with epilepsy than women without epilepsy. These are the risk factors which are involved in the woman with epilepsy. Odds of cesarean section were increased in polytherapy group than monotherapy. So detection of congenital defects, how will detect? Because we have given 5 milligram of folic acid, but still there can be defects. Even high-risk drugs like sodium valproate are still the drug of choice for certain epilepsies, and discussion of risk and benefit is mandatory. The fetal anomaly scan at 18 to 20 plus 6 weeks of gestation can identify major cardiac defects in addition to neural tube defects. So there are cardiac defects and the neural tube defects. For the cardiac defects, I want to discuss that there is no role of routine fetal echocardiography in detecting congenital heart disease. Even routine fetal echocardiography is not recommended in the patients, in the screening of the patients who themselves have cardiac disease. If the patient is having cardiac disease, for the screening of their pregnancies, we will not use routine fetal echocardiography. These ultrasound, the anomaly scan are very reliable for detecting any cardiac defect, along with neural tube defect, obviously. So biochemical screening with maternal serum alpha fetoprotein, when combined with ultra sonography increases the detection rate for neural tube defect to 94 to 100%. So as I have mentioned in spinal cord injury, that sometimes patient comes with the history of spina bifida, and she was having, patient was herself having spina bifida, and now she comes that I want to make sure that my child is not having spina bifida and 20-week scan is normal. So she asked in the exam sometime that what is the blood test which can confirm more that my baby is not having spina bifida. So which blood test she was referring to is a maternal serum alpha fetoprotein. So monitoring of serum anti-epileptic drug level. Routine monitoring of serum anti-epileptic drug level in pregnancy is not recommended. We will not monitor the serum anti-epileptic drug. This is not routine. This is the neurologist, if he needs to monitor, he will choose the patient, because normally there has been discussion regarding the anti-epileptic drug level. Should uh, should we see the therapeutic drug is working or not? It does not need the serum monitoring, but they have seen that the monitoring can be based on clinical feature. If patient is improving clinically, then we will titrate the dose accordingly. We do not need the routine monitoring of serum anti-epileptic drug. The level of most anti-epileptic drugs are known to fall in pregnancy due to changes in pharmacokinetics of absorption, metabolism, and hemodilation, and excretion in pregnancy. Level of lamotrigine are known to fall by up to 70% in pregnancy. So you will remember this point, that lamotrigine in pregnancy, its clearance is more, and so we need to increase the dose of lamotrigine, because on the baseline, the medication patient was taking in the pre-pregnancy, we need to increase in pregnancy, lamotrigine. Same is the rule, because with the lamotrigine, when we will study the contraception, we will see patient with hormonal contraception like progesterone, or oral progesterone, yeah, or COCP. When we give those hormone to the patient, there is a risk. There is not risk of contraception failure, but there is a risk of increased seizure in the patient. So we need to increase the dose of lamotrigine. Although COCP and progesterone only pills are UKMAC3 in epileptic patient, but still, if patient is persistent that I want to take this, we have explained all the risk and benefit of that type of contraception, and she have given all the necessary information to make informed decision, and she is competent and she can make her own decision. Then we will tell her that we will increase the dose of lamotrigine, because with the pregnancy and with the hormonal contraception, lamotrigine doses will fall. There is no clear evidence to show that therapeutic drug monitoring reduces the risk of seizure deterioration compared with monitoring based on clinical feature. Clinician will need to take into account other features such as suspicion of non-adherence, toxicity, intractable seizure in their decision on therapeutic drug monitoring. So I will say, I already mentioned the clinician will choose the patient to whom they want to do the routine monitoring of serum anti-epileptic drug in pregnancy. So these are the patient in which you have suspicion of non-adherence. So you want to see whether patient are taking properly or not. So you will do the check for adherence. So you will do the serum level monitoring, toxicity, and intractable seizures. Adverse effect of anti-epileptic drug in pregnancy. Anti-epileptic drug carry an increased risk of depression with features such as low mood, inability to plan, organize thoughts, poor concentration, tiredness, irritability, or anger. Risk is more when high dose of polytherapy is used. Healthcare professionals should be alert to signs of depression, anxiety, and neuropsychiatric symptoms in mother exposed to anti-epileptic drug. Early referral to perinatal mental health team is required if they are having cancer. So, or whenever you see the management in the pregnancy, you have to mention some things like type of anti-epileptic, dose of anti-epileptic, polytherapy is increase the depression, it increase the risk of congenital abnormalities, it increase the risk of growth retardation. So all these factors depend upon the anti-epileptic drug, its dose and type. So reducing risk of seizures. Women with epilepsy should be regularly assessed for falling risk factor for seizures such as sleep deprivation and stress, adherence to anti-epileptic drug, and seizure type and frequency. If admission is required antenatally, Women with epilepsy at reasonable risk of seizure should be accommodated in an environment that allows for continuous observation by a carer, partner, or nursing staff. With epilepsy will not be left alone if they need to be admitted. And if in the pregnancy, even we will tell the patient, you will not sleep alone. There should be someone around you so that they can see that if patient is having risk of seizure, and they should be well informed. The relatives of the epileptic patient should be well informed, and they know what should they do in the case of seizure and where to contact. Advise not to sleep alone at night. Individuals with unwitnessed seizures are at high risk of SUDEP, with nocturnal seizure being an independent risk factor. Fetal monitoring, we will do the serial growth scan from 28 weeks are required for detection of small for gestational age babies. The odds are 3.5 times higher in women with epilepsy exposed to anti-epileptic drugs compared with those not taking anti-epileptic drugs. There is no role of routine antepartum fetal surveillance with cardiotocography in women with epilepsy taking anti-epileptic drugs. So when we discuss the anti-epileptic drugs, there are two types: enzyme-inducing and non-enzyme inducers. So enzyme inducers are the carbamazepine, phenytoin, phenobarbital, pyrimidine, oxycarbazepine, topiramate, and eslicarbazepine. So these are the names of enzyme-inducing drug, because when we mention the contraception, so these enzyme inducers will have different contraception choices than non-enzyme inducer, because non-enzyme inducer can have all type of contraception except lamotrigine. Lamotrigine, in lamotrigine, they can have all UCAMAC 1 except POPs and COCP. These two are UCAMAC 3. But for enzyme inducers, because they have limited choice as compared to non-enzyme inducers. So these enzyme inducers are considered to competitively inhibit the precursors of clotting factors and affect fetal microsomal enzymes that degrade vitamin K, thereby increasing the risk of hemorrhagic disease of the newborn. So we have mentioned that with anti-epileptic drug, there's a risk of maternal postpartum hemorrhage and the hemorrhagic disease of newborn. So point is this: should we do something or not? Because previously we used to give them vitamin K to the mother, but now it is not recommended, because they say if we know there's a risk of postpartum hemorrhage, we can be vigilant and we can have better options in the management of third stage of labor. We can manage the active third stage of labor, and then we can have all the things ready for postpartum hemorrhage than giving vitamin K to the mother. But for the hemorrhagic disease of the newborn, we will give the vitamin K to the baby. Role of vitamin K in preventing hemorrhagic disease of the newborn and maternal hemorrhage. All babies born to women with epilepsy taking enzyme-inducing anti-epileptic drugs should be offered 1 milligram of intramuscular vitamin K to prevent hemorrhagic disease of the newborn. There is insufficient evidence to recommend routine maternal use of oral vitamin K to prevent hemorrhagic disease of the newborn in women with epilepsy taking enzyme-inducing anti-epileptic drug. We will not give the vitamin K to the mother. We will give to the baby at birth 1 milligram intramuscular. There is insufficient evidence to recommend giving vitamin K to women with epilepsy to prevent postpartum hemorrhage. So we will not give any vitamin K to the mother for the prevention of newborn hemorrhagic disease or maternal postpartum hemorrhage. Timing and mode of delivery for women with epilepsy based on seizure control. If seizures are controlled, then timing of the woman with epilepsy is not changed, and mode of delivery will not affect it. But place of delivery obviously will affect it, because patient is having the risk of seizure. So patient should be in the hospital setting. As I have mentioned, there are 4 options: home delivery, and standalone midwifery clinic, and standalone and along with the hospital midwifery units. And the third one is the hospital unit. Third one is alongside midwifery unit. So timing and mode of delivery for women with epilepsy based on seizure control. Most will have an uncomplicated labor and delivery. Diagnosis of epilepsy per se is not an indication for planned cesarean section or induction of labor. So women with significant deterioration of seizure, only if the significant deterioration of seizures which are recurrent and prolonged and who are at risk of status epilepticus, elective cesarean section may be considered. No evidence on the optimal timing and mode of delivery in women with epilepsy. Antenatal steroid cover, if it's required, then we can give it. If patient is at the risk of preterm delivery, we can give it. Although there was a thought that if a patient is taking enzyme inducer, should we double the steroid dose or not? No, we should not. We know that enzyme inducer degrade the lot of drugs, but we will not. Doubling the antenatal corticosteroid dose for prophylaxis against respiratory distress syndrome in the newborn is not recommended. So intrapartum care, women with epilepsy should be concerned that the risk of seizure in labor is low. Minimize if she is compliant to medication, if she is avoiding the stress, dehydration, then she's not deprived of sleep, then it's not increase in labor. Minimize risk factors for seizures such as insomnia, stress, and dehydration. Long-acting benzodiazepines such as clobazam can be considered if there is a very high risk of seizure in peripartum period. So how can we know that a patient is having very high risk of seizure in the postpartum? There are some points in the history which can tell us that patient is at high risk of having seizure in pregnancy, in the labor. Like anti-epileptic drug intake should be continued during labor. If this, these are another point that we will not even, we have mentioned that anti-epileptic drug will not discontinue as in the antenatal period. Also, it should not be discontinued during labor. If this cannot be tolerated orally, a parenteral alternative should be administered. Tonic-clonic seizures occur in about 1 to 2% of women with epilepsy in labor, and within 24 hours of delivery in a further 1 to 2%. So this is also a question asked multiple times in part 2 exam, that what is the percentage of the tonic-clonic seizures which occur in the woman in labor and in the first 24 hours of delivery. So recommended method of analgesia in labor for women with epilepsy, they can have a lot of options except pethidine. And for the pethidine, it should be replaced with diamorphine and other some other drugs which are used for general anesthesia. They cannot use. So pain relief in labor should be prioritized in women with epilepsy. Obviously, if they are in stress and in the pain, they will not sleep properly. It will in turn increase the risk of fit in the patient. So pain relief in labor should be prioritized in women with epilepsy with options including transcutaneous electrical nerve stimulation, TENS, nitrous oxide, oxygen, Antonox, and regional anesthesia. Pethidine should be avoided or used with caution in women with epilepsy for analgesia in labor because it is lower the seizure threshold. So diamorphine should be used in preference to pethidine. An epidural can be considered early to minimize precipitating factors for seizures during labor, such as overbreathing, sleep deprivation, pain, and emotional stress. We don't want to give these stress to the patient, and which in turn increase the risk of seizure and complicate the delivery. In general anesthesia, if general anesthesia becomes necessary, it is prudent to avoid anesthetic agents such as pethidine, ketamine, and sevoflurane. The first two are known to lower seizure threshold, and third may have epileptogenic potential. The place of delivery with women with epilepsy, the woman with epilepsy at risk of peripartum seizure delivery should be in a consultant-led unit with facilities for one-to-one midwifery care and maternal and neonatal resuscitation. Because if they are high risk of having seizures, they need proper care, and we will be ready to have the seizure control. And she might need the prophylactic clobazam. And also, if there's a fit, we need to manage the medication which are not available in the midwifery unit. And the fetus baby is need to be monitored by continuous electronic fetal monitoring. Continuous electronic fetal monitoring is recommended in women who are at low risk of intrapartum seizure. Fetal monitoring may be carried out by intermittent auscultation. So one of the risk factor of that you can have idea that patient is having increased risk of fit in the labor. That if the patient is having seizure 1 month prior to conception, within 1 month, prior to conception. And if the patient is having history of seizure in the previous labor, then there is a chances she will have also seizure in this pregnancy. So some patient ask about water birth. This is a separate question, separate topic which was explained in guidelines. So I also mentioned it separately. Patient can ask, we can have water birth for the pain relief. We want to avoid the medication, and water will be there for pain relief. But women with epilepsy who are not taking anti-epileptic drug and who have been seizure-free for a significant period may be offered a water birth after discussion with their epilepsy specialist. The rates of induction of labor are higher in women with epilepsy than in those without epilepsy. There is no evidence that anti-epileptic drug affect induction agents. We can, if the patient need induction, we can give, and there is no specific change in the induction agents. Decision to use water for analgesia and birth must be based on seizure risk status due to risk of drowning. So if the patient is having a seizure in labor, what will we do? Seizure in labor may lead to maternal hypoxia due to apnea during the seizure and fetal hypoxia and acidosis secondary to uterine hypertonus. So we can give if we know that patient is having the risk of seizure in pregnancy, seizure in labor. We can give the prophylactic clobazam is considered in the following circumstances: recent convulsive seizure, recent history of seizure provocation by stress or sleep deprivation, or a history of seizure in previous labor. So if the patient is having a seizure in the pregnancy or 1 month prior to pregnancy, and she is having history of seizure in the previous labor, then she's a high risk of having seizure in the labor as well. We can give the prophylactic clobazam. The risk from clobazam, such as respiratory depression, clobazam has its own side effects, such as respiratory depression in the newborn, need to be balanced against the benefit due to seizure prevention. So anti-epileptic drug should not be discontinued in labor. It is mentioned again and again. If not tolerated orally, anti-epileptic drug may be given parenterally. This includes phenytoin, phenobarbital, sodium valproate, and levetiracetam. These can be given parenterally. So now these are I have mentioned the prophylactic management of seizure. Now, if the patient has seizure in the labor, so optimum management of epileptic seizure in labor. Every obstetric unit should have written guideline on management of seizure in labor. Seizure in labor should be terminated as soon as possible to avoid maternal and fetal hypoxia and fetal acidosis. Benzodiazepines are the drug of choice. Left lateral tilt should be established alongside maintenance of airway and oxygenation at all times. In those with IV access, if the patient has already maintained IV access, then lorazepam given as IV dose of 0.1 milligram per kg, usually a 4 milligram bolus, with a further dose after 10 to 20 minutes is preferred. Diazepam 5 to 10 milligram administered slowly IV is an alternative. This is the patient who has IV access. If the patient does not have IV access, then diazepam 10 to 20 milligram rectally, repeated once 15 minutes later, if there's a continued risk of status epilepticus, or midazolam 10 milligram as buccal preparation are suitable. If seizures are not controlled, consider administration of phenytoin or phosphophenytoin. The loading dose of phenytoin is 10 to 15 milligram per kg by IV infusion, with the usual dose of an adult of about 1000 milligram. And continuous fetal monitoring is recommended in women at high risk of seizure in labor and following an intrapartum seizure, because we know that it will increase the risk of seizure, increase the risk of fetal hypoxia and fetal acidosis. If there is persistent uterine hypertonus, consider administration of tocolytic agents. After the mother is stabilized, you have controlled the seizure, continuous electronic fetal monitoring should be commenced if the fetal heart rate does not begin to recover within 5 minutes, or if the seizure are recurrent, expedite delivery. It says expedite delivery. This may require cesarean section delivery, or if vaginal delivery is not imminent. If the patient is fully dilated and you can use the instrument to reduce the labor, you can do that. The neonatal team should be informed as there is risk of neonatal withdrawal syndrome with the maternal use of benzodiazepine and epileptic drug. So once a baby is delivered, now baby should be seen by neonatologist, because now baby will be observed for the sign of withdrawal of anti-epileptic drug, and for its own cognitive deficit will be monitored for the long time under care of pediatrician. So for the postpartum management, overall chance of seizure during and immediately after delivery is low. It's relatively higher than during pregnancy. Although it's low, but relatively higher than during pregnancy. Women with epilepsy should be advised to continue their anti-epileptic drug postnatally. This is mentioned in every pod. Mothers should be well supported in postnatal period to ensure that triggers of seizure deterioration such as sleep deprivation, stress, and pain are minimized. So in the postnatal period, the most common things are sleep deprivation, stress, and pain. So these patients should have the proper sleep at night. Period of maximal seizure exacerbation was the third day peripartum. Third day peripartum period in women with generalized and partial seizure. So first 3 days are critical. The risk was highest in women who had seizure in the month prior to pregnancy compared with those who were free of seizure during the same periods. Sleep deprivation related seizures could be reduced by arranging help for the mother, especially for nighttime feeds. If the mother breastfeeds, storage of breast milk pump during the day might be beneficial. Many women are on higher dose of anti-epileptic drug at the end of pregnancy compared with their pre-pregnancy dose. So in the postpartum period, physiological changes that occurred in pregnancy, such as increased renal and hepatic clearance and hemodilation, are reversed. And these women become at risk of toxicity for high anti-epileptic drug doses. So we need to reduce that drug of anti-epileptic, which was increased in pregnancy. So increase in the dose of anti-epileptic drug that occurred in pregnancy should be clearly documented in the notes with a comprehensive plan to liaise with the neurological team to taper the dose in the first 10 days after delivery. So increased risk of seizure in the peripartum period up to 3 days. And we should taper off the dose of anti-epileptic drug in the first 10 days after delivery. Otherwise, there will be toxicity. So if symptoms of anti-epileptic drug toxicity develop in the puerperium, patient will have drowsiness, diplopia, and unsteadiness. Urgent neurological review is needed. So this was the care of women in pregnancy and postpartum. Now, for the babies, how these babies will be monitored? Should be monitored for adverse effects associated with anti-epileptic drug exposure in utero. Mother should be informed that the risk of adverse cognitive outcome is not increased in children exposed to anti-epileptic drug through breast milk. So we will now patient will be concerned whether I should breastfeed or not. So she says that I am taking anti-epileptic drug. So we will tell that anti-epileptic drug exposed in utero, that is having more adverse cognitive outcome, but from the breast milk, it's not increased. So she should not stop the breast milk feeding to the baby. So if there is a problem in the cognitive deficit, it was from the anti-epileptic drug in utero. The rates of transfer of anti-epileptic drug to the neonate through the placenta and breast milk vary. Breastfeeding has not been shown to affect the cognitive outcome at 3 years of age in children who were exposed in utero to lamotrigine, sodium valproate, phenytoin, or carbamazepine monotherapy. Babies born to mothers taking anti-epileptic drug may have adverse effects such as lethargy, difficulty in feeding, excessive sedation, withdrawal symptoms with inconsolable crying. Individualized assessment should be made for the level of post-delivery monitoring required for withdrawal symptoms, and for any sign of toxicity. So this is especially important in premature babies, and serum levels of anti-epileptic drugs in the baby should be checked where appropriate. So psychomotor, overall, if patient needs to know that breastfeeding with anti-epileptic drug will affect the development of the baby or not. So we can say that psychomotor development of the breastfed children was better at 6 and 18 months compared with those who were not breastfed or were breastfed for less than 6 months. So it's benefit if they are breastfeeding the babies. These are the medical management. Along with that, patient needs some other counseling, like advice should be given regarding safety strategies and care of the baby. These should be given in the preconception, antenatal, and postnatal period. Postnatal mothers with epilepsy at reasonable risk of seizure should be accommodated in single rooms only when there is provision for continuous observation by a carer, partner, or nursing staff. Seizure can result in accidental injuries to the mother. and the baby, such as drowning, falls, burns, and electrocution. Safety strategies include nursing the baby on the floor, using very shallow baby baths, laying the baby down if there is a warning aura, not bathing the baby unaccompanied, wearing identification tags, avoiding sleep deprivation and alcohol if prone to myoclonic jerks. Women should ensure that family and friends have knowledge of first aid and emergency contact procedures. Uh, the mental health is very important for all pregnant patients. We assess the patient in the pregnancy, in the postnatal period for their mental health and by proper screening questions for depression and anxiety. So these patients are at increased risk of depressive disorder as compared to normal other patients who are not having epilepsy. Women with epilepsy should be screened for depressive disorder in puerperium. Rates of postpartum depression are higher in women with epilepsy than women without epilepsy, 29% versus 11% in controls. Risk factor for depression are multiparity, anti-epileptic drug polytherapy. Mothers should be informed about the symptoms and provided with contact details for any assistance. So up till now, we are discussing the total antenatal, intrapartum, and postpartum care of the patient with the epilepsy. So now we will discuss the contraception in the woman who is taking anti-epileptic. This is very important topic, and I will discuss in detail in the next video. Thank you so much.